Assalamu alaikum. Now I would like to talk about salicylate toxicity. What does it mean? In epidemiology, in salicylate toxicity, there is excess injection of aspirin. Aspirin given, it is easily gettable because lots of the house there is hyper, lots of the house there is MI patient, lots of the house there is stroke patient. So the patient who is suffering from MI and stroke, they easily get this aspirin. If excess ingestion of this aspirin or other salicylates, oil of wintergreen, they can got salicylate toxicity. Liver metabolism gets overwhelmed and slower renal excretion, prolong elevated salicylate level. In brain, what does it do? It can cause tinnitus, dizziness, altered mental status, cerebral edema, and seizure. In heart, it can cause arrhythmia. In liver, it can cause hepatitis because liver metabolism gets overwhelmed, so it can cause hepatitis. In lungs, there may be tachypnea, pulmonary edema. On stomach, there may be vomiting, nausea. On system, there may be metabolic acidosis and fever. Diagnosis is serum salicylate level. Diagnosis is serum salicylate level. So for diagnosis, we can do serum salicylate level, and another thing we can do is that is ABG, arterial blood gas. In arterial blood gas, we can get mixed acidosis and respiratory alkalosis because salicylate toxicity can have mixed metabolic acidosis and respiratory alkalosis. We can do basic metabolic panel. Hypokalemia may be present due to GI loss in the setting of vomiting. There may be osmolarity. Serum osmolarity should be obtained whether osmolar gap is present or not, and lactic acid and keto acid level should be seen. CT scan as lung, if it involves a lung, can have pulmonary edema. In case of severe toxicity, pulmonary edema may be seen, and neurotoxicity can happen. Then we need the CT scan of the head. We need the CT scan of the head. Okay, for now the management. Management, most important, activated charcoal or alert patient within 2 hours of ingestion. IV sodium bicarbonate enhances salicylate excretion. Sodium bicarbonate enhances salicylate excretion. And hemodialysis for severe ingestion, pulmonary edema, and renal failure. Management in a brief: activated charcoal. It binds salicylate in the GIT and decrease systemic absorption. Given within 2 hours of the ingestion, avoid inconfused or obtune patient. Risk of aspiration: IV sodium bicarbonate alkalinizes urine and serum and enhancing salicylate excretion. It requires a large volume of fluid to be administered. Requires large volume of fluid to be administered. An initiation of dialysis: inability to tolerate large volumes of sodium bicarb, pulmonary edema, and there may be renal failure and persistent acidosis. Severe condition may comes with a shock, seizure, CNS dysfunction, cerebral edema. If we found these feature, then hemodialysis should be done. Hemodialysis should be done. So, what is likely ingested agent in a patient who overdosed and presents with fever, tinnitus, vertigo, tachypnea? It is aspirin. Aspirin can cause mixed respiratory alkalosis and mixed respiratory alkalosis and anion gap metabolic acidosis. Look for pH in the setting of mixed respiratory and metabolic disorder. And another important thing in the management, endotracheal intubation should be avoided if possible because adequate hyperventilation is difficult to maintain mechanically results in worsening acidemia. There is a special consideration where we know that in children, Ray's syndrome is a rare, potentially fatal condition occurs in children. Given salicylates or aspirin for a viral illness, influenza, varicella, the pathophysiology likely involves mitochondrial dysfunction from aspirin, which leads to impaired fatty acid metabolism and acute hepatic steatosis. Acute hepatic steatosis. So that is all about salicylate toxicity. It's a very unique topic. Hope you enjoyed.